Saying which are the main mechanisms of resistance to antiangiogenics is a controversial issue. There are several theories, but it's very different, for example, for EGFR mutations in which T790M is clearly a mechanism of the resistance. For antiangiogenics, we know that we have mechanism of intrinsic resistance because we can see a lot of patients not responding immediately to the first line. So in this case, we have intrinsic resistance, but we have also mechanism of acquired resistance. In all the two cases with the different mechanism, we have an overexpression of some factors. For example, the overexpression of the receptor of VEGF, we can have, in particular VEGF-A, we can have the overexpression also of PDGF, and we can have also the overexpression of FGF. For the acquired resistance, we have also other mechanisms, such as the recruitment of progenitor of the vascular cells, such as BMDC, and we can also recruit some pericytes.
When you ask about resistance to angiogenic therapy, it's both primary and acquired. Primary would be maybe a lot of patients don't benefit from it, so it might be that the tumor isn't even driven by VEGF. Maybe VEGF is not being made by the tumor, and it's not co-opting and bringing the vessels in. So there might be other mechanisms of angiogenesis and other inhibitors required other than blocking VEGF-A. Why would resistance develop? I guess resistance could develop if the tumor learned how to bring blood vessels in the absence of this factor, if there were other pathways involved. But I think the bigger problem is just primary resistance, primary effect. I'm not as worried about secondary resistance, but this field is good, but it's not great as far as the biology and our understanding of it, the biomarkers and the understanding of it. So we know that these agents have some effect. The effect's reasonable, but it's not a home run. It's just a very solid improvement in standard of care. That's why I think we need to look at these VEGF inhibitors and think, how can we make them even more valuable in our lung cancer treatment, combining them perhaps with immunotherapy or other targeted therapies?
We have controversial data on the use of continuing antiangiogenics because we don't have a very large randomized controlled trial on the issue. So the question is that continuing to target angiogenesis can be a good strategy because we see that the subgroup analysis of trials, in particular the REVEL, 15% of patients were already treated with bevacizumab, and when they progressed, they were treated with ramucirumab, and the same for nintedanib also if the proportion of patients was less. And I think that we have also to consider that in other diseases, such as colorectal, we have several data that targeting angiogenesis for all the disease of the patients can be feasible and useful. In lung cancer, this is something that can be, but we have more studies to confirm the data.
From a biological point of view, it makes sense to inhibit angiogenesis in first line, second line, and in all lines of the disease. Angiogenesis is a hallmark of cancer. So in the studies, for example, analyzing ramucirumab or nintedanib, patients previously treated with bevacizumab were allowed to be included, and these patients also benefited of the addition of second-line antiangiogenic drug. So there is some rationale to maintain the inhibition of angiogenesis throughout the disease evolution.
Well, we know now that these different anti-angiogenic agents all have a different working mechanism. One of the interesting theoretical concepts could be that you also sequence your treatment of these anti-angiogenic agents. You could imagine that when patients are progressing after bevacizumab, that there could be a response to ramucirumab or another agent just based on the fact that they have a different kind of working mechanism. And that's, for now, as far as my knowledge is, it's only theoretical. I don't know of any clinical data on that, but I think it's an interesting concept which we can look at.